I might as well get started. We'll start off with a little bit of housekeeping. So I'm Mike MacDonald. I'm a cardiologist at the Harley Street Heart and Vascular Centre, and we're talking today about hypertension in the young. And this first slide here is from the Singapore Heart Foundation about their heart wellness program. And what I will say is that everyone is muted already and your video is not on. If you have any questions, please at any time just drop them in the Q&A. It can be quite difficult when I'm doing the presentation to see who's answering questions. So what I'll try and do is actually go through them at the end if we have some time. And if there's not enough time, then I'll drop you individually an email just to go over if you have any questions about what's being talked about. So I think it's about 1 o'clock, so we can maybe just get started today. I'd like to thank you all for spending your lunch hour here today, and this talk will be roughly probably about 45-50 minutes, about 10 minutes Q&A at the end, and it's the Singapore Heart Foundation is providing the CME points for this. So today's topic is hypertension and the young. And just turn my video off. So what the main issues we're going to be going through, the main areas, first of all, we'll introduce the hypertension problem, and then we'll look at the more specific evaluation of a young person with hypertension, what you need to look for, and then the treatment of hypertension in young people. Followed by a couple of cases to go over the management investigation, some of my own patients. And we all know that hypertension is a massive problem, and you can see here there's 1.6 billion hypertensive patients in the world, and only 1 in 7 of these people are controlled, which is a staggering statistic, particularly when you consider the amount of morbidity and mortality that's associated with hypertension. And in Singapore, the prevalence of hypertension is quite high. And here, this chart is from the Singapore National Health Survey back in 2010. And I've highlighted the younger groups. So age of 30 to 39, the prevalence is about 8%. And in the age group of 40 to 49, it's about 17%. And you can see that in both age groups, it's higher in males than it is females. And then when you get up into the 50s and 60s, you get prevalence of about 50%. So there's a very high prevalence in Singapore, and a significant number of young people are also hypertensive. And it's a problem because if you have hypertension, your mortality increases, your morbidity increases, you increase risk of heart attacks and strokes. And the higher your blood pressure, the higher that risk. This chart just shows you the CV risk associated with progressively increasing amounts of blood pressure by about 20/10. You can see the staggering increase in risk by the time you get to very high levels. And when you put that into context of 1 in 7, only 1 in 7 people being controlled, that's a lot of morbidity and mortality. And this is just to illustrate what happens when you lower blood pressure, even by a small amount. So this study was the UK Biobank study, which is about almost 500,000 people in the UK. These people are genetically characterized. What they did was they looked at genetic associations with lower blood pressure and lower LDL, and they worked out that if you had a lifelong lower systolic blood pressure, but just by about 10 millimeters of mercury, then that was associated with an almost 50% reduction in major coronary events. And when you added that in with a small LDL reduction of about millimole per liter, then you lowered your future risk of CV events by about 80%. This just highlights how if you treat blood pressure and lower it at a young age, and have lifelong low blood pressure, you will reduce your overall risk of cardiovascular events. And I'm sure you all know this, that the hypertension is the most common chronic medical condition presenting to primary care in Singapore, and it apparently made up about 17% of all polyclinic visits in 2009. It's a lot of healthcare visits, so it's very high on everyone's mind. And we do see, well, no, I do see quite a lot of young patients with hypertension, and often they're surprisingly young. So I'm just going to talk about the evaluation of a young person with hypertension. Now, what age counts as young? I still consider myself young, and I'm mid-40s, so I've kind of gone for a less than 50 approach, because I think that is a younger age group. It's quite rare to see hypertension in children, and I don't see children in my own practice, but I think we'll look at the less than 50 years age group as the young patients. So in young patients, secondary causes are much more common, and okay, I've just been instructed to inform everyone that the CME points will be submitted for you, so we'll do that at the end of this talk. So yeah, so secondary hypertension is much more common in the very young, and the younger you get, the higher your chance of having a secondary cause. And when you look at 18 to 40-year-olds, about 30% of them will have a secondary cause or an identifiable cause of their hypertension. And if you can identify a cause, then you can potentially cure it, which has big bearing on that person's risk of events in their future. And what's also known is that the interventions that we use to treat secondary causes later in life are often less effective because organ damage and vascular changes have already occurred. So it's quite important to try and identify these causes in young people, modify them, cure them, and before they start to cause problems. So in all our patients with hypertension, we follow this workflow. We, number one, establish that we have the correct diagnosis, and we run some routine tests in all patients. This is largely to risk stratify patients and assess for end organ damage. Yet we risk stratify patients because that allows us to determine what type of treatment that they get. And then we decide if they need secondary cause assessment, because most patients do not need assessment for secondary causes of hypertension. And the key question is, when should we consider looking for secondary causes? And there are a number of groups where you should be looking for secondary causes of hypertension. If patients are less than 30 years of age, there is a high chance they're going to have some cause. So I think that all these patients we should look for secondary cause. If they're less than 40 with particularly high blood pressure, i.e. more than grade 2, then again they should be considered for secondary cause screening. If they've already got quite extensive hypertensive mediated organ damage, then again that's probably someone you should be considering. If someone's been stable and then suddenly their blood pressure control worsens, then you should be looking for a secondary cause. Resistant hypertension, grade 3 hypertension, people that have had a stroke less than 50. If anyone's had a family history of pheochromocytoma and they have hypertension, and also patients with clinical clues. And this is part of the important points. One of the important points of this presentation is that when these hypertensive patients come in, to be looking for the clues that suggest the secondary cause. These might be signs or symptoms or biochemical clues. And I'll go through each clue and what we should be looking for. So this table is from the ESC guidelines, and it just details the incidence and typical causes of secondary hypertension according to age. And when you see children, they have about 70 to 80% of them will have an underlying cause. And the usual causes are renal parenchymal disease, aortic coarctation, and monogenic disorders. And it's a similar group of disorders that lead to hypertension in adolescence. In young adults, about 19 to 40 years of age, you're looking at renal parenchymal disease, fibromuscular dysplasia, especially in women, and again, these rare monogenic disorders. When people get into the middle ages, then you're more likely to have primary aldosteronism, sleep apnea, Cushing's, pheochromocytomas. And then as you get older and you start to develop vascular disease, then you start to see renovascular, atherosclerotic renovascular disease coming in to the causes. And in all these age groups, actually, thyroid is something that's important. But you can see that the percentage with an underlying cause gets higher as they get younger. And this is a kind of rough flow chart of what to look for in our hypertensive patients. So I think all patients, when they come and see us, we should confirm the diagnosis first of all, whether that's with home blood pressure monitor or an ambulatory blood pressure monitor. And then look at, have they got any dietary or drug causes of their hypertension? I think it's very easy to forget the different drugs that patients can be on and be causing the problem. In all patients, then we do a detailed history, physical examination, and baseline tests, and then we risk stratify. The baseline tests should include some blood tests, an ECG, a urine analysis, and in some patients, fundoscopy as well. And then, if you are concerned about a secondary cause based on your initial examination and blood tests, then you look at the age of the patient, and that's when you think about what secondary cause you need to screen for. And in very young patients, so less than 18, you should be thinking about a renal ultrasound to check for renal parenchymal disease. You should do an echo for coarctation of aorta, and also considering these rare monogenic disorders. Under the age of 40, you should be looking for renal parenchymal disease, thyroid problems. In women, fibromuscular dysplasia, and again, the monogenic disorders. And the tests for this group would be a renal ultrasound. And renal ultrasound is pretty good at picking up FMD, but you can have false negatives in some cases, and at that point you would go for an MRA, a CT angiography. And then above the age of 40, probably hyperaldosteronism, sleep apnea, Cushing's, pheochromocytoma. So then you get into this series of investigations with renin-aldosterone, sleep studies, and the urinary metanephrines and cortisol. And I'll go through this in a little bit more detail. And then as you get into older groups, then you're looking at renal parenchymal disease and renovascular disease in the older patients. And I'll go through each of these different causes and the different investigations. So first of all, the medications that increase blood pressure. So in the initial assessment, it's important to take a medication history that includes non-prescribed medications. And highlighted in the dark blue are the ones that are more common. So non-steroidals, COX-2s. Some patients can take an awful lot of these at home, and that can lead to hypertension. Patients on the oral contraceptive pill, psychiatric drugs like buspirone, fluoxetine, lithium, tricyclics, illicit drugs such as amphetamines and cocaine and nicotine. These TCM, ginseng, ephedra, or mlav-1, sympathomimetics, decongestants and dying pills. So all these things, and some of these are not prescribed, so it's important to take quite a detailed medication history. But in addition to all these drugs, there's also things like ketoconazole, bromocriptine, of course, steroids, prednisolone, methylpred. Patients currently on chemotherapy with a VEGF inhibitor in particular. EPO, Sudafed, immunosuppressants, and in diet, patients that take an excessive amount of licorice can also push your blood pressure up. So just a word on the oral contraceptive pill. So it can raise the blood pressure and within the normal range. So these patients won't have hypertension, but they'll have a high normal. But it can also cause secondary hypertension in a small group of people. And it was probably more prevalent when the doses of estrogen were higher in the older preparations. And it used to be said that about 5% of patients in the OCP had some form of hypertension, but it's now thought to be roughly less than 2% with the more modern lower dose pills. And you can actually see rises of up to 8 millimeters of mercury So in young women, it's certainly something that needs to be considered as one of the initial causes. And I'm not going to say a huge amount about these rare genetic causes because there'll often be a diagnosis of exclusion. They're more common in the younger patients, the children or young adults, and they largely affect the sodium reabsorption in the kidney, and they're usually associated with a suppressed renin concentration. But there's a number of different genetic causes here, like Liddle's, Gordon's, Geller syndrome. I'm not going to go into detail here, and these should be managed largely by a specialist. But again, going into the more common causes that we will all see in our practice, so this is a table that's just going to describe the cause. It's prevalence in the overall hypertension population, and the signs and symptoms that you should be looking for in your patients, and then the investigations that should be done to identify these conditions. So first of all, sleep apnea has a pretty high prevalence as being a cause of hypertension. You have, these patients will often be obese, so they'll be maybe heavy snorers, have daytime headaches and somnolence, and you diagnose it with a polysomnography. Renal parenchymal disease then comes in about 2 to 10%. These are often asymptomatic, but they may well have proteinuria, have some nocturia, anemia, or on examination they might have some renal mass, such as in polycystic kidneys. And so the investigations are obviously renal panel, urinary ACR and dipstick, and a renal ultrasound. And then we have the renal vascular group of diseases, and these can be split into the atherosclerotic, which tends to affect older patients that have widespread atherosclerosis. So, for example, if your patient had peripheral arterial disease or was a diabetic and a smoker, that might point towards atherosclerotic renal vascular disease. This is not going to be seen so much in the younger population. You do see it sometimes, but this atherosclerotic renal vascular disease is largely in older patients. If you give them an ACE or an ARB and they have a big jump in their creatinine of about 30 to over 30%, usually about 50%, it's suggestive of renal artery stenosis. And then what you do see more often in younger patients is fibromuscular dysplasia, and this is younger women that can be associated with spontaneous coronary artery dissection, and you can often hear abdominal bruit. And the standard method of investigating these is a renal artery Doppler, plus or minus CT or MRA of the renal arteries. And then on to the endocrine causes. So primary aldosteronism is surprisingly prevalent, and it's a lot more prevalent than we used to think. Suggestive signs, patients are usually asymptomatic, and only a minority of patients get hypokalemia. So it's usually just picked up on screening using the renin-aldosterone ratio. Fields and Cushing's are rare, and they should only really do the investigations for assessing these if they have symptoms. So patients, particularly obese, the striae, then look for Cushing's. If they've got the classic of paroxysmal hypertension or headache or palpitations or perspiration, and do the screen for pheochromocytoma. And the standard diagnostic test here is a 24-hour urine collection. I think in all patients with hypertension that present, they should all get their thyroid checked. So that'll be picked up on the initial screen, and everyone should get their calcium checked as well to try and pick up hypoparathyroidism. And then coarctation, very rare, usually picked up in young children. Classic signs that you have are they have upper limb hypertension, often have a differential between the upper and lower limbs, or the right and the left arm with delayed pulses, and you'll hear a murmur. And if someone's young, it can be picked up with a transthoracic echo relatively easily. And as you get older, they tend to use an MRE to have a look at the aorta in more detail. But as I said, it's usually very young children that the cohort gets picked up. I do know somebody who was picked up in the Middle Ages. Sorry, not in the Middle Ages, but when they were middle-aged, but it was a relatively minor cohort. Okay, so around 5 to 10% of patients with hypertension will have a raised aldosterone. So primary hyperaldosteronism is far more common than we initially thought. And this study here was done in Italy, and it was a secondary care clinic looking at consecutive hypertension patients, about 1,200 of them. And they assessed patients with aldosterone-renin ratio and then underwent further assessment with imaging and adrenal vein sampling. And about 5% of their population had aldosterone-producing adenoma, and about 6% had idiopathic hyperaldosteronism. So that's almost 10% or more than 10% of patients having some form of hyperaldosteronism. And this is a slightly skewed population because it was a secondary care population, but a lot of these patients had relatively new hypertension under assessment, and they weren't all resistant hypertensions. So primary hyperaldosteronism was initially described by Kohn in the 1950s and was called Kohn syndrome after him. And it's excess aldosterone production by an adrenal adenoma, or unilateral or bilateral adrenal hyperplasia, or an adrenocortical carcinoma, and can also be associated with excess growth hormone. And it's not always associated with changes in potassium, and about half of patients have a completely normal potassium level, so you often won't pick it up on your renal panel screen. It's the most common cause of drug-resistant hypertension, and actually 25% of these patients can have a normal aldosterone level. And to test it, so you measure the aldosterone-renin activity in the morning, about 2 hours after waking. And they will tend to have a high aldosterone and a suppressed renin, so therefore the aldosterone-renin ratio tends to be increased. And this was from the Italian study that I just described, and many of these patients do not have hypokalemia. And when you look at this first chart here, this is the percentage of patients that have hypokalemia presenting. You can see the patients with primary hypertension, 7%, patients with an aldosterone-producing adenoma, less than half had hypokalemia, and those with idiopathic hyperaldosteronism had only about 17% had hypokalemia. So they'll often have essentially normal electrolytes. And it's more common with the increasing severity of the blood pressure. So if you take the different grades or different groups here of primary hypertension, idiopathic hyperaldosteronism, and aldosterone-producing adenomas, then the higher the grade of hypertension, the higher prevalence rate of these different conditions. So you're more likely to pick it up in patients with higher blood pressure. These patients are grade 2 when they present, or grade 3. And it can be cured by surgery. So this is a flowchart of the assessment. When you're doing the initial aldosterone-renin ratio, it's okay for the patient to be taking most medications. Generally, you need to stop spironolactone, eplerenone, and amiloride for about 6 weeks prior to the test. The rest of the blood pressure medicines can probably continue. If it's a positive test, then you go into confirmatory testing, usually with some kind of saline load, and then they'll get imaging of the adrenals, followed by adrenal vein sampling. And some of these patients can then be offered laparoscopic adrenalectomy, and others can be treated with an MR antagonist. So it's a treatable condition, so it is important, quite important to pick it up. So moving on to the next one, we've got fibromuscular dysplasia. I don't know if any of you have seen that. I had one patient just last year with this, and young women usually, ages 30 to 50 years old. And it's an idiopathic segmental non-atherosclerotic non-inflammatory disease of the arterial wall musculature. And you can often see this pattern on the right-hand side here, which is on MR angiography and angiography, showing this beaded pattern to the renal arteries. And it usually affects the middle or the distal third of the main renal artery. And in about 60% of patients, it's bilateral. You can pick it up with renal Dopplers. It's a good test, but there is a false negative rate. I think it's about about, it'll pick up 70 or 80% of cases. So if you do have high clinical suspicion, so you've got a young woman who's got, maybe the Doppler hasn't picked anything up, there's nothing else that kind of points to the cause of her hypertension, then you should consider moving on to doing an MR angiogram and just to have a look at the renal arteries in more detail. Now this is, I think, one of the big problems, and it's obstructive sleep apnea is very high prevalence in Singapore. It's thought to be about 30%. Now there are obviously risk factors, mainly being male, obese, or middle-aged. And in patients that have resistant hypertension, it's very common that they've got obstructive sleep apnea. Classically, you're going to be looking for the symptoms of sleep apnea with snoring, headache, unrefreshing sleep. And the diagnosis, you can obviously screen patients with one of the questionnaires and then arrange them to get a sleep study. And if you'll often see in these patients that when you do your 24-hour ambulatory blood pressure monitor, you might get a little clue as to which patients have sleep apnea. I'll show you a little bit later on, but these patients tend to lose their diurnal BP response, and you'll see their blood pressure does not have that natural drop in the evening at night when they're sleeping, and it tends to stay the same or go up slightly when they're sleeping. And you'll see that I'll show you an example of that a bit later, and that might give you a little clue as to whether you should be looking for sleep apnea. And the CPAP, it does help. CPAP does allow, it does lower your blood pressure slightly, and it makes you more responsive to the antihypertensive drugs. And obviously, if you do identify sleep apnea in these patients, then you can start to target lifestyle improvement, try and get them to lose weight, trying to reduce their the effects on their sleep. And this is a study which basically looked at the prevalence of secondary causes of hypertension in patients with very resistant hypertension. And you can see here that 64% of patients, I think this is an American study, had obstructive sleep apnea. So it's super important to look. If you've got patients that don't appear to be responding to 3 medications, and have a serious consideration of whether they've got some sleep apnea. And then pheochromocytoma, very rare tumor arising from the chromaffin cells of the adrenal medulla. And classically, these patients have paroxysmal hypertension, and they get headaches, pounding headaches, palpitations, and perspiration. And there was a study done, I think it was in the Cleveland Clinic, where most patients have at least one symptom. So it's very unusual to be asymptomatic. So I think probably if you're going to be assessing patients for this, then they should at least have some symptom that might be suggestive of it. About 2/3 of patients will have at least 2 symptoms of the headache, palpitations, and perspiration. And the test is a 24-hour urine collection to look for your meta-adrenalins, and then a CT if it's abnormal. And similarly, another rare cause of secondary hypertension, so Cushing syndrome, looking for moon phases, central obesity, proximal muscle weakness, and bruising. And most of it is actually caused iatrogenic from corticosteroid use, but only about 20% of iatrogenic cases actually have hypertension. And the testing is a 24-hour urinary-free cortisol. So again, you certainly don't need to screen every patient for this, but if you have a patient with striae who's obese, then consider doing a test to pick this up. And then aortic coarctation. So it's mainly in children and it's picked up. You do sometimes pick it up in adults, perhaps if it's not so severe. I had one case actually who I think was picked up, was in our case, picked up actually very late, and it caused severe heart failure. But basically they have a coarct to the distal part of the aortic arch, usually near the subclavian, and it can be around about the subclavian origin, and the position of it affects what the clinical signs are. So often the signs, you'll have upper extremity hypertension, delayed or decreased femoral pulses, and low blood pressure in the extremities, and adults will sometimes have rib notching their chest X-ray. And I think I said before, testing in kids is a transthoracic echo, and in adults it's an MR angiogram. So just going to move on to the treatment here. So first of all, the treatment of young patients with hypertension, there's been no specific trials that have looked at young patients with hypertension. It is actually a relatively rare condition. So the bulk of hypertension is people in their 50s and 60s and 70s. But what we do know is that there were young people in these clinical trials, and most of the clinical trials, the young people appeared to respond in a similar manner to older patients. But in all our patients with hypertension, we follow this flow of getting the diagnosis, doing the routine tests, risk stratifying, and then deciding if they need secondary causes. So first step is obviously screening for and diagnosing the hypertension. And these are just some flowcharts showing what we should be doing. And if a patient is hypertensive, then you should be considering using perhaps home blood pressure monitoring or ambulatory blood pressure monitoring to confirm that diagnosis first of all. And I think in young people in particular, it's you're committing them to a very long period, their whole life on blood pressure medication. So I think getting that correct diagnosis at the start is super important. So I definitely would encourage the use of ambulatory blood pressure monitors in this group in particular. And these are the categories of blood pressure, looking at the ambulatory BP over the course of 24 hours, a mean greater than 130/80. So these are the tests that I would suggest in pretty much all patients, and I'll go through each of them individually. So first of all, in red, the blood tests. So hemoglobin, you might be looking for polycythemia there, and hematocrit. You want to check a glucose and HbA1c to assess if the patient has diabetes or impaired fasting glucose. You want to check their lipids, which are needed for risk stratification, and the renal panel to assess for kidney dysfunction. Uric acid, people with a higher uric acid appear to be at slightly higher risk than people that have a normal uric acid. Liver function tests, doing a urinalysis, looking for proteinuria, an ECG to check for LVH. And just a word in ECGs. ECGs they're very good at picking up LVH, but they're not as good as an echo for identifying LVH. So a completely normal ECG can sometimes, the patient can still have left ventricular hypertrophy. In some patients, they should have fundoscopy. So if they're diabetic, they should definitely have fundoscopy. And if they've got quite severe hypertension, as in grade 2 or 3, then they should definitely have fundoscopy. Some patients should get an echo, not all patients. If they have an abnormal ECG, or they have symptoms or signs that might suggest they've got some LV dysfunction or LVH, then definitely get an echo. So for example, if the patient has some breathlessness or poor exercise capacity, then I would definitely go for an echo. You can consider an ultrasound to look at the carotids or the aorta, to look for any signs of vascular disease, and also to look at the kidneys. And the renal ultrasound should be done if you're screening for secondary causes, or if they've got protein in their urine or impaired renal function. And the reason why you're doing all these tests is, number one, to do simple screens, number two, to identify hypertensive mediated organ damage. And the utility of HMOD is that it allows you to properly risk stratify patients. So if you have somebody who's in a low cardiac risk group, when you calculate their estimated 10-year risk, if they already have hypertensive organ damage, it pushes them into a higher risk group. You should be thinking about treating earlier rather than just waiting to see if lifestyle measures improve. I'll go into that in a bit more detail. So a big part of your assessment of hypertensive patients is risk stratifying them. And if a patient is grade 1 and high risk, you're going to go straight for treatment. But if they're grade 2 or more, you're going to go straight for treatment anyway. But in all patients, you want to try and categorize them into low, moderate, high, or very high risk. Now, the very high risk group are people that already have severe CKD, or they have clinical cardiovascular disease. so they've had an MI or a stroke, or they've got documented imaging evidence of cardiovascular disease, or they've got diabetes with target organ damage, or a very high 10-year risk. People that are high risk are people that have already got hypertensive LVH or moderate CKD, or any of them that have got quite significant rise in one of the risk factors like cholesterol or very high blood pressure. And then moderate risk is people with grade 2 hypertension and a score risk of 1 to 5%. But you can see from this chart on the right that if you have evidence of HMOD, you're going to fall into that high risk group. If you've got CKD or diabetes, you're going to be in this kind of high risk group as well with hypertension. But it's not an exact science for stratification, and when we use our calculators and we come up with a score, there'll also be a good chance that it's going to be falsely low, because a large part of risk is driven by age, and young people will often score very low on these risk calculators. So there are other risk modifiers that we can use. So if someone is falling into the low to moderate risk category, then number one, we can look at hypertensive mediated organ damage. But this chart here shows some of the other things that can change your risk score. And if people have a family history of premature cardiovascular disease, you're probably going to stratify them up a bit in the scoring charts. If they've got other autoimmune or inflammatory disorders, if there's obesity or AF, they're all going to push your risk up as well. So when you do the risk score, you also have to think about, are there things that are going to modify that risk? Because these risk scores are not 100% accurate, and they give you a general view on risk, but then you have to modify it based on the patient in front of you. And then what levels of blood pressure are we targeting when we're treating? So if we look at the guidelines for younger patients, so not super young, but 65 years and less, ideally we should be looking at targeting 130 or lower, down to between 120 and 130 for systolic, with a diastolic between 70 and 79. Now there are slight differences in the different groups. So CKD is 130 to 140. But the rest of the patients are all between 120 to 130 for systolic as a target. But obviously that's quite a difficult target to achieve, but if we can all start with trying to get down all patients down to less than 140 over 90, and then pushing most patients even lower if we can. But despite our best efforts, about half the patients who currently do not even achieve a target of less than 140. So these are less than 130 over 80 is often quite a difficult thing to achieve. So when should we initiate our treatment? Now, this is standard advice for all hypertension patients. So grade 3 patients and grade 2 hypertension should have immediate drug treatment in all patients, and aim for quick blood pressure control within about 3 months. On top of that, we're going to give all patients lifestyle advice. And then grade 1, you should have immediate drug treatment in patients that are high or very high risk. So those with established cardiovascular disease or renal disease or evidence of organ damage. And patients in the low to moderate risk, you can probably give a period of lifestyle intervention before initiating blood pressure drugs. But certainly all high risk patients should be aiming to get control quickly. And the treatment strategy, this is the treatment strategy from the ESC guidelines. So they say that initial therapy should be with a dual combination tablet. So that's 2 drugs at a low dose and a single pill. And they actually highlight the number of pills a person should be on at each step. The patients that can consider monotherapy are those that are low risk grade 1 hypertensions. Those that actually have only got a systolic of less than 150. So they're actually, it's not going to be too difficult to get them to target. Or in very old or frail patients can be started on monotherapy, but most other patients should be started on a combination tablet with an ACE or ARB plus a calcium channel blocker or a diuretic. And the next step, again, is to try and use a combination tablet again, an ACE and ARB plus a calcium channel blocker plus diuretic. And then you move on to resistant hypertension, where you add in spironolactone. And at any point in this pathway, you can consider beta blockers. And the drugs should be titrated to the patient. So if they have a history of heart attack or heart failure, they should be on a beta blocker. So it's individualized to the patient, but we should always try and reduce the number of drugs that the patient is, sorry, the number of tablets that the patient is taking. And when it comes to combination and fixed dose, this is a little slide about all the different guidelines and who recommends it. So they all recommend, so go right down to the bottom of this little table, when to use single pill combinations. Pretty much every set of guidelines recommends single pill combinations these days. And I'll just go on to why. The fact is, first of all, most patients require more than one drug to get their blood pressure to less than 140/90. In this study, about almost half or 2/3 of women needed 3 or more drugs to get them properly controlled. So patients are going to be, or realistically, going to be on multiple drugs to control their blood pressure. We know that rather than increasing the dose of a drug, you're actually better to add in another drug. You get a much better reduction in blood pressure. This chart shows in the blue is what happens when you add a drug from another class, and the orange is when you double the dose of the same drug, and you can see the change in the blood pressure ratio. And just adding another drug gives you a far better reduction in blood pressure than increasing the dose of the same drug. So rather than giving them one tablet, optimizing the dose, you should just step in straight away and add in a second tablet. And the problem with all our hypertension patients is keeping them taking the tablets. This is a chart, looks at after you start treatment with blood pressure drugs, how many patients remain adherent. And at 3 to 6 months, only about 30% of patients are fully adherent. About 60 or 70% are about partially adherent. So anything we can do to improve adherence is super important. I think this is particularly important in young patients, because when you're less than 40 and somebody tells you you've got to start 3 different tablets in the morning for the rest of your life, it's going to be hard for you to continue taking these drugs in the long term. So using a combination of a fixed dose tablet for these patients, I think, is even more important. They're far more likely to take 1 tablet in the morning than they are 3. And this chart just shows you what happens if you give people free dose versus fixed dose combinations. And you can see that when people are on free dose combinations, they have a far lower persistence and compliance. And if you have better adherence and compliance, you have better blood pressure control. So people are taking their tablets. Makes sense. If you're taking their tablets, their blood